talk a lot about fighting cancer, the surgeries, the chemotherapy, the radiation. But there's another battle that happens alongside, one that's rarely discussed, often invisible, and almost always underestimated. The battle in the mind. Dr. Soumitra Shankar Datta is a psychiatrist who has dedicated his career to this invisible frontline. He heads the Department of Palliative Care and Psycho-oncology at the Tata Medical Centre, Kolkata, a department that exists because someone recognized that treating cancer means treating the whole person and not just the tumor. Before returning to India, Dr. Soumitra spent years at some of the UK's most prestigious medical institutions, the King's College Hospital and the Maudsley. He's trained doctors across the world on how to communicate with cancer patients. And he's researched something that often goes unspoken: why people delay seeking help, even when they know something is wrong. Today, we explore that part of cancer care that doesn't show up on scans. Dr. Datta, welcome to the Voice of Courage.
Thank you for having me.
Psycho-oncology is a word most people have never heard of. Could you help us understand what this field actually does?
Yeah, psycho-oncology is a branch of medicine that looks after the psychological care of cancer patients and their family members. So we treat depression, anxiety associated with cancer, and we also manage risk of suicide and other things. Psycho-oncology clinicians are keenly interested in doctor-patient communication, and we work on that, and a lot of trainings and communication skills are delivered by psycho-oncologists. There is also a robust research body that is developing in the field of psycho-oncology on various aspects of psychological and social aspects of cancer.
Right. So, Dr. Datta, when someone receives a cancer diagnosis, what happens psychologically? So, walk me through those steps, from a mental health perspective.
Nobody is ready for the diagnosis of cancer, and it is probably a very big shock for anyone receiving it. Yeah. The psychological space at the point of diagnosis is complex because you have the patient who might be thinking, will I live? The family member who is in the room might think that how expensive will be the treatment, and the doctor in the clinic might be thinking, what is the stage of the disease and what treatment will this patient be best suited for? So all of these three people have to come to a common ground psychologically before anything begins. So I think people adjust to that over time, over the first few weeks, and then treatment begins. But if there is overwhelming emotions, sometimes we are involved, and luckily many of these emotions are transient, and people start with the treatment over the next few weeks. Yeah.
So, Dr. Datta, you've been one of those fortunate who've also worked in the UK as well as in India. So, for our audiences, if you can help us understand, what are the cultural differences, between how a patient and the family would process a cancer diagnosis? Would there be any cultural differences between the two countries?
Yes. By and large, I have practiced medicine in various parts of the world. I think there are more similarities than differences. But if you ask specifically between UK and UK, in UK, largely cancer care is delivered free of cost for the patient. And there are robust screening programs, so cancer is detected at an earlier stages. Right. And the social construct of the cancer as a result is such that people are less scared. In Europe, people are also more individualistic, whereas our research in India has shown that patients actually want their families to be involved in the journey of cancer, not at the cost of excluding themselves, but having it together. So there are slight differences, but there are lots of similarities as well.
Dr. Datta, you've trained as a child psychiatrist as well. So how different is it, when a family has to come to terms with a child's diagnosis? If you could help us understand what exactly goes on, in the minds of a family dealing with such a diagnosis.
Psychological aspects of children who are medically unwell has been one of my areas of interest. By and large, often children, you would be surprised to see that they actually cope very well. Some of the research we have done has shown that very young children have information needs where they're worried about tests that they'll undergo, will it be painful? And slightly older adolescents often worry about the impact of cancer on themselves. When will they be back at school? Families often go through a change. They had the dreams and aspirations of a healthy child who suddenly get a diagnosis of cancer, and they may blame themselves. And we try to share with the families that cancer is not brought on by any parenting practices or anything. It's a biological disease. However, the outcome of pediatric cancers are very good.
Right.
So, nowadays, that's a way where, this hope often makes families cope with this diagnosis better, and they engage, and, children get better and they get back to normal life.
Absolutely. Having said that, Dr. Datta, depression and anxiety is, very common in cancer patients. So how often does this go unrecognized?
Yeah, 1/3 of cancer patients are depressed at some point in their journey. And you were absolutely right that, there are times when it might go unrecognized for several reasons. One is that for cancer and its treatment, some of the symptoms like fatigue, fragmented sleep, might have an overlap with symptoms of depression, and people might get confused about recognizing them. Also, there are patients who might feel that feeling low is a natural reaction to a very difficult situation they're going through. Clinicians need to have the sensitivity to recognize depression. So these are the reasons why depression might go unrecognized. But good news is depression in cancer is curable. So if you ask about the cognitive symptoms, like do they feel hopeless, are there crying spells, and then as the patient has an assessment and we go ahead with the treatment, most patients with depression in cancer would get better.
That's really, very positive and so great to know. But also, Dr. Datta, there's that pressure on patients, constant pressure, stay positive, stay strong. I mean, does that actually sort of, create, is sometimes a little more harmful in that sense, or, is that required?
I think you are spot on. Now the pressure of this staying positive industry sometimes can put an additional pressure on cancer patients. There is a very interesting book by Barbara Ehrenreich called Smile or Die. And she says that, she was made to feel either she should smile or she should be dead. And what we need to accept that feeling sad, angry, upset, these are normal human emotions. And all of us go through that. And if these things happen, you should let people go through that and vent it out. If it is such that it is overwhelming, then of course patients require professional help. But normal mood is not a straight line. There are ups and downs. So you're absolutely right that this staying positive is important, but at the same time, not at the cost of putting up a facade, which is not true.
Yeah, absolutely. We come to something very, very important, a very important topic, which is, body, body image in cancer. I mean, we see that a lot of hair loss, visible scars, changes in the body. So how do, patients actually process this? And, how do you navigate this, when someone would approach you?
The pressure from airbrushed reels is on everybody to look good. And cancer patients have changes in their skin, their hair, and of course, this is devastating for many patients. As mental health professionals, we look after patients and we try to work on the cognitive aspect of it, what they feel about themselves. In the last few years, the social media has also given a lot of positive messages. People in public life have discussed about their cancer journeys. So that has helped as well. So being bald can be beautiful. So I think when patients go through these, being able to accept some of them and being present to listen to what they feel is very crucial. And we give the option for patients sometimes. Some people would like to be as they are and go around without hair like some of the celebrities did.
Absolutely.
Others might want a scarf or a wig.
Yes.
It's for the patient to choose.
Sure. Yeah, that's another way of looking at it actually, and come to the positive side. Fear of death, that's the elephant in the room. So how would you, as a psycho-oncologist, come to terms with that, or, help someone facing their mortality?
As a medical student in the 90s, I did not have a single lecture on palliative care. And, science has definitely improved the life expectancy of people in India. So from 33 years in 1947, now it is 70. But with more and more involvement and investments, life won't go on to eternity. So it's important that we acknowledge that death is a reality. And I think for that, we have moved a long way from, now there is a specialty of palliative medicine which looks after the social, psychological, and physical aspects of death and terminal illnesses. Patients are not afraid often of death, but they're afraid of dying because they're worried about, will it be painful? What will happen to my family members when I'm not there? So that's the area where, as psycho-oncologists, we have a conversation with the patients. It's difficult, but if we can come to that and speak friendly way, but at the same time, it shouldn't be abrupt, but at the same time, you allow the patient to express their thoughts, their grief, their hopes and desires. That often brings in a sense of closure.
True. So what you're saying is the process. We have to help them navigate that process.
Yes.
So true. Beyond medication, what is it that families can support patients with psychologically? Medication is something that in any case is their treatment protocols. Beyond that, what would you suggest?
I think for families, the first step is to share the treatment plan with the patient, because everybody would want to be involved in what's happening to their body. So that's the first thing. And I would also say try to be as normal as possible. So I have had few patients who reflected later on that some of their family members made them feel that as if they will die in the next 2 weeks. So that's not helpful. But families are the biggest source of support for cancer patients as well. So say a patient with head and neck cancer after surgery, the family member, learns the way the patient needs to be fed. And often patients can be sent home earlier than if there was no family. So there is tangible support that families can do, and not having been hospitalized for a longer period has its benefits on less financial cost, less infections and other things. So families are a fantastic source of support. If family members become so overwhelmed with emotions that they're unable to be useful, sometimes they might need help for themselves. But by and large, I think families needs to be reinforced that they're doing the right thing and it's not their fault, and being with the patient is what helps.
Yes. So I was actually coming to that. We see a lot of, pressure on the patients, or there's a lot of focus on the patients. But very often it's the families that are ignored, or the families that also, have their own psychological journey. So how would you as a psycho-oncologist, help the families navigate their own journey that they're going through when they're dealing with the cancer patient?
Yeah, let me tell you a story about a gentleman who was husband of a patient called Shalini. He was an IT professional and had the luxury of working away from his office. He could work from home. But once Shalini developed cancer, she had to be supported for many hours a day. And this is a new change her husband had to adjust to. And of course, employers are usually supportive if a family member is going through cancer. There are lots of indirect costs as well. So, you may not travel as much, may not take the promotion which you were supposed to take. And also, feel upset about if the patient is in palliative care or in terminal cancer, then the impending grief can be difficult. So these are again emotions which families go through, and that's why we are human.
So true, Dr. Datta. The other point that I think a lot of our audiences would like to know is how should we communicate with loved one who has cancer? What is it that we should be mindful of? What hurts? What accidentally, we would say something and that would sort of trigger a reaction. What is it that we should be mindful of when we deal with a loved one who has cancer?
Yeah, we had a patient, let's call him Mohan. So Mohan was a young man. He was diagnosed with an advanced cancer, and his family was very loving. And Mohan hated it when his families focused only on the treatment, because he did not want to be stripped of his personhood, because he liked watching cricket, he wanted to go out with friends. And I think if families are supportive of not stripping people away from their personhood and being as normal as possible, but at the same time when the patient needs, they need to be willing to listen, because
True.
a large part of what we do is actually being able to actively listen to someone. So I think these are things which they can do for patients.
Absolutely. So that's with adults. We would also like to know, when it comes to a child and parents receiving a child's diagnosis, how do they process that? How do we help them, process the diagnosis of a child, especially for parents? That's really painful, I would think so.
Children developing cancer, it's a very difficult time for a parent, for the father or mother. They often blame themselves, and it's not their fault, but let me reflect about my own journey. So when I became a doctor, I trained in CMC Vellore. I traveled far away, and I lost my father around that time. Now, I would think for a while that maybe my going from Kolkata to Vellore precipitated this death. But it's probably not true. Death is something which would happen.
Correct.
So similarly, family members, if when they have a child with cancer, they might blame themselves, and they may be worried, will this child live? The worst thing which professionals can do is ask them, do you have another child? Because they are grieving about this child.
Absolutely.
So I think that's something which you should avoid. And pediatric cancer, actually by and large, if diagnosed early and treated, has a very good outcome now. 80 to 90% patients may be better, provided they are treated. And supporting the family that they need to be present and support the child going through it. Missing 1 or 2 years or 6 months of school is not a big deal. And supporting them as a unit is what makes sense. Children are very perceptive. They understand what's happening to them. So we need to have some ways of engaging them into the treatment, because cancer treatments go on for sometimes months, sometimes years. So you can't have an uncooperative child. So giving them developmentally friendly explanations to them what's going on, usually they're okay.
Dr. Datta, you've been through this journey, like you mentioned, with your own parent. So from a caregiver's perspective, we all know that burnout is real. What is it that families, members should watch out for in themselves, being caregivers?
Yeah, meaning I should correct myself that my father did not die of cancer, but he had a chronic disease which he died of. But sometimes you would want to give full on whatever you have, your resources for the patient. And this, you might actually neglect your own emotional and physical health.
True.
So if you are physically healthy and emotionally healthy, you will be a better caregiver.
Absolutely.
So we often tell patients, family members, if they're on any chronic medications, not to neglect their health. Take breaks. Ask their friends if they can be supportive and do some of the mundane chores like shopping or cooking, things like that. And usually with a cordon of care around the patient and the family copes better.
Yeah. Dr. Datta, you have been researching on what delays are caused and why do people come in seeking, help late and delayed. What is it that your research has primarily focused on, and what is it that you would like to, point out at this point in time?
I'll talk about two specific pieces of research. One is a generic project through King's College London and Wellcome Trust. We did in Tata Medical Centre, talked about the cancer journey. So lack of awareness of the symptoms of cancer, having less access to cancer care near home, or being afraid of approaching oncology hospitals having not a very robust system of communicating between them, so patients have to redo investigations often. So all of these factors often lead to delay. And this was what we found. There was also a specific research on women with ovarian cancer where we found high attachment anxiety, and being part of a joint family or a multi-generational extended family, as we called, was associated with delay in ovarian cancer. Attachment is, a phenomenon of a child who turns to an adult, mommy, I'm hurt. So the person whom you turn to is the attachment figure.
Right.
So that happens in an adult. So these patterns are often set, and if there is attachment anxiety, you may be delayed in getting help. True. In joint families, it could be because that, women support each other. You would think that joint families are very supportive, which they are, but in nuclear families, if the woman has a symptom, the family stops and probably they go for help earlier. Right. So the family is very central in cancer care, and as long as we identify the causes of delay, at least we would be able to have, public health messages where the delay could be reduced.
True. Dr. Datta, there's stigma around cancer. There's also stigma around mental health. When these two come together, how do we break through?
That's a very moving question. There is perceived stigma against mental health. There is perceived stigma against cancer. And one way, if you want to understand that stigma, is when you strip someone from their experience of being that person to a tainted class. So stigma of mental health could be, portraying patients with depression with a head clutter image like this, or stigma of cancer could be increased by only portraying patients with bald heads, because these don't encompass the entire experience of being the patient. Good news is that with many celebrities and public figures coming out with their cancer journeys, the stigma has reduced a lot. So you see people with bald heads getting married nowadays, and there are lots of positive messages against stigma as well. As a consultant psychiatrist working in a cancer hospital, I have not felt that these two stigmas add up. So in fact, patients are quite happy to have someone who would be listening to their emotional journey.
Right. That's something very, very interesting that, I think our audiences can take away with them. If someone watching this is struggling, either as a patient or a caregiver, struggling psychologically, what is it that you would like to say to them, and what kind of a message would you want to pass on through this very platform?
1 in 4 people will go through an episode of depression at some point or the other, and more likely than not, somebody might be in that state who is listening. I think, I would first try to tell them that they need to have some lifestyle changes, like be kind to themselves, exercising helps, having a hobby, speaking to people whom they like. And if the symptoms of sadness or tearfulness or whatever the emotional symptoms they're going through, if they persist, please do access professional help from a psychiatrist or a psychologist near your home. Many of the mental health conditions are completely curable. There are so many people who have talked about their mental health conditions now through the media. So hopefully you will be better in a few months' time.
Dr. Datta, what would you want every oncologist, every doctor treating cancer to understand from a psychological dimension?
I think in 2026 or around this time, people have understood that cancer care is a teamwork. So patients, if you want to satisfy them, you have to shrink their tumor, but at the same time look after the pain, the nausea, the physical symptoms, as well as the emotional symptoms of sadness and depression, anxiety. So both of these add to the quality of life, and there is so many doctor suicides in India, and the burnout literature for anywhere in the world actually stems from oncology. So involving psychological aspects of care in cancer care is a no-brainer. So the younger oncologists, I think, are much more open about this because the scenario has changed. Accepting mental health is very much accepted now, and most cancer centers now are developing a psycho-oncology unit.
Right. Coming to palliative care, something that is not really spoken about much or not really understood. From your perspective, what is it that palliative care, what kind of a role that palliative care can play in modern oncology?
I think it plays a very central role because a large proportion of patients in India would require palliative care. In fact, palliative care themselves have changed the definition that it's the care of the physical symptoms, psychological symptoms, and the spiritual symptoms of a patient, and supporting patients and family members together. That's very central in oncology now. So a patient may have a completely curable cancer but have pain prior to surgery for head and neck cancer or oral cancer, which is a common cancer in India, and may benefit from pain management. So our hospital has 2 consultants in palliative medicine. We have 2 consultant psychiatrists. So we work as a team to look after the patients, to address their physical symptoms like nausea, pain, and also their emotional symptoms together. There are spiritual nurses, there are psychologists, and a specific facility called Premashraya, which has the hospice. The hospice caters to patients, some for symptom management in palliative care and some for end-of-life care. So I think over time, we would encourage young doctors to take up palliative medicine as a specialty that they specialize on. And I can see that palliative care having a much more central role in the next few decades of care.
Thank you, Dr. Datta. Thank you for sparing the time to come with us and to help us educate our audiences. Thank you.
Happy to be here.
There's a kind of courage we rarely talk about. Not the courage to fight, but the courage to admit you're struggling. The courage to say, I need help, when everything in you just wants to power through. Dr. Datta reminds us today that healing isn't just about what happens in the body, it's about what happens in the mind, in the heart, in the spaces between a patient and their family. If you or someone you love is going through this, please know the fear is normal, the anxiety is normal, the sadness is also normal, and there are people whose entire job is to help you carry that weight. This is the Voice of Courage. I'm Vanessa Damania. Be brave enough to ask for help.